Yeah, is it visible
Yes,
now?
sir.
Okay,
Yes,
right. Okay. So, this is a small presentation where, because you people have not done this case, I don't want to trouble you by asking so many questions on that. This will give you rapid revision or points to remember in the examination. So, whenever you get a case like this, cleft lip and palate, first thing what you should be able to do is identify what type of the defect is it, whether it is unilateral, bilateral, complete or incomplete. Then you should know something about the embryology and development of the defects leading to the cleft formation. This is a very, very commonly asked question. And what are the complaints by the informer? Because you will be usually getting children less than 1 year for these surgeries. So you have to depend only on the parent, either the mother or grandmother, for all the complaints that they have been having. So the informer, you have to ask about the appearance, whether the defect was noticed right from the time of birth, whether it has been on the same size or increasing, what are the feeding difficulties they had, whether there are any recurrent infections both in the chest as well as in the ear. And if they come a little later, say at about 2 years or 3 years, they can have speech abnormality. So depending upon the time of presentation, because not all babies will come at the age of 2 months or 3 months. Some of them, especially from the rural areas, they are not still aware of that there is this is a treatable condition. So you may have patients coming with an older age also when they started speaking. Then examine the child for appropriate growth for the age. So you must know what should be the expected weight of the baby based on the age of the baby. So if the baby is not matching that weight at the time of examination, it may be a underweight baby because of the poor nutrition. And because of the feeding difficulty, some majority of the children may be underweight and not having enough nutrition, and there may be delay in the development of milestones, and there will be, you have to look for presence of infection in the chest or ear, and always look for other congenital abnormalities or syndrome. So they commonly classify this cleft not only as unilateral, bilateral, complete or incomplete. There is a classification also syndromic and non-syndromic cleft lip and palate. But the syndromic clefts coming for the regular surgeries are quite rare. You get non-syndromic children much more commonly. So for them, you have to know whether this is a unilateral or complete or incomplete. This is common to all, whether the baby is syndromic or non-syndromic. But when they come with a syndrome associated with that, they always have problem of airway, and that will be a more challenging thing. And you have to anticipate difficult airway in all these cases, especially if they have a left side cleft which is quite wild, or if they have a bilateral cleft with a protuberant premaxilla, or if they are associated with syndromes like Peary-Robin, Treacher-Collin, or Klippel-Field, etc. So anticipated difficult pediatric airway is the dictum of cleft lip and palate. Then continuing the points to remember, you have to minimally investigate the child. Don't ask for too much of this, because most of them are otherwise healthy unless they are associated with a syndrome or a congenital heart defect. You ask for minimal hemoglobin, coagulation profile. If there is a history of recurrent LRA, you can ask for a CXR, that is a X-ray chest. And if there is an otitis media, you can ask for ENT opinion. And you can get some dental help for feeding the baby if they have found it very difficult for feeding the child. And you can get a cardiology opinion if you find a VSD and or any other cardiac anomaly. Then the plan for surgical correction should be, lip should be repaired at the earliest, because lip starts growing faster. Another reason, and the wider the gap will become more and more if you wait for too long a period. And the second reason is, or the primary reason is, you want to correct the lip and make the baby suckle at mother's feed so that the growth will be normal, and the immunization and the immunity point of it is much better if the baby takes a mother's milk compared to the market foods. So the lip is always repaired at the earliest, and for that they can ask you about the Skillner's rule of 10, which is they should be operated by the age of 10 weeks, which is 2.5 months, and the weight of the baby at that time should be 10 pounds, not kilos, because Mubin said the baby was 3 kilos at birth, which means it is about 6.6 kilos. I mean 6 pounds. So it should be 10 pounds. It would have gained at least 4 pounds in the 3 months. And hemoglobin should be 10 grams and WBC count should be less than 10,000 to indicate that there is no any residual infection. Then the plan of induction should be decided whether it is going to be inhalation or intravenous. If you don't anticipate any difficult airway or a difficulty in mask ventilation or laryngoscopy and intubation, you can plan for intravenous induction. Otherwise, majority of them are preferably induced by inhalation induction using oxygen sevoflurane by either what is called the step-up method and step-down method. That is, you use 6 liters of oxygen and start with 2% sevoflurane and increase it slowly after every 4-5 breaths to 4%, 6%, and up to 8%. Or you can start with a higher percentage and start reducing it to achieve the desired state of. The common question that I always ask is, how do you know if you do inhalation induction, how do you know that the child has come to the surgical plane of anesthesia for you to do any intervention, like starting an IV line or a laryngoscopy? You can answer.
Eyeball movements.
First and foremost, what is the easiest thing to observe?
Shallow breathing.
Breathing, not shallow breathing. It is a deep, slow breathing. Initially, the respiration will be fast and shallow. But as the child becomes under, that is, loses consciousness, the rapid shallow breathing is replaced by slow, deep breathing. Second thing is the abdominal muscles will become relaxed, and child, however much the tummy may be, it may become a little scaphoid. And lastly, when you pull the upper eyelid and look at the eyeball, initial stages, the eyeball will be moving right and left, which is called the roving eyeball. That will come to the midline and that will get fixed in that center position. So the fixed central gaze of the eyeball is the correct method of assessing. These 3 signs, both the change in the respiratory pattern, relaxation of the muscles, and the eyeball sign are the 3 important things which tell you that the child has come to the correct plane of anesthesia. Then only you should start any intervention. Then you have to calculate and keep all the drug doses correctly diluted, because the drugs have to be given in a very diluted fashion. You cannot use them like an adult taking 1 cc or 2 cc. So if you want to give 1 microgram per kg body weight of fentanyl, fentanyl comes in 1 ml 50 micrograms. So you have to dilute it in such a way that you make 1 microgram per every ml, and then try to give exactly the 4 micrograms or 8 micrograms what you want to give according to body weight. So all the drugs should be diluted and kept ready, and you have to calculate the fluid requirement that you are going to give, and load them also with an appropriate equipment, which I am going to show you later. Then intraoperative monitors, apart from whatever monitors we are using in the multiparameter monitors, we have to compulsorily have a precordial stethoscope in all these patients of cleft lip and palate, especially palate surgery, because the surgeon will be using a mouth gag and the tube may get migrated up or down. So you have to have a precordial stethoscope, which is very, very important. And you have to plan for multimodal analgesia, including appropriate local anesthetic block. So like 10 commandments, these are the 10 points you have to remember while answering this case scenario. Now coming to the pictorial description, these are all the various types of cleft that you can see. See, this is the most simplest form. There is just a notching in the upper lip. This is also the second incomplete form where it is, you can see the alveolar bone is intact here, but the lip is in two parts. But still it has not entered the nasal floor. It is the nasal sill is now in continuity. And here if you see, this alveolar bone is also not there, and it has entered into that. This is much more wider than the last one. So if you see this is the unilateral cleft lip spectrum. So this is the microform, or what is called the notching. This is what is called the incomplete cleft lip, because it is not involving the alveolar bone or the nostril sill. This is complete cleft lip and the alveolar bone. Both the alveolus are also involved. And the fourth tip is there is a complete cleft lip along with the palate. It has gone on into the hard palate also. So all the palate is also involved. So there are four types like this. Similarly, if you come to these cases, you find this is a bilateral cleft, but this is also incomplete because it has not gone into the nostril. So it is a bilateral incomplete cleft. This one is a microform of notch in the right side, whereas the left side is a complete cleft. You have not having the alveolar bone continuity. The lip has gone onto the nostril sill, and the nose is not in complete shape. And the third type is it is a incomplete on the right side and a complete on the left side. Okay, so this is a microform and a complete. This is an incomplete form and a complete form. And the last one is the complete bilateral cleft of both the lip and palate. So this portion which is projecting in between these two clefts, this is called the prominent premaxilla. This may be sometimes too protuberant, like the face of Anjanaya. So there it will be too bulging. In that case, the first surgery they do will not be lip repair. They will do the reduction of this protuberance by breaking the bone and then inserting it back, so that the alignment of these two lateral elements can be made easier. So you bring it close to this and do what is called a lip addition, and then do a secondary correction later on. Okay, that's a little complicated, but then this will be a very tough challenge for intubation, because this prominence will hide your vision. Now this is another pictorial description of the cleft palate, where it is only, this is called incomplete palate, where only the soft palate and the uvula you can see in two pieces. This is a incomplete cleft of the palate. The hard palate is totally intact. And this type of cleft you will commonly see only in Peary-Rabin syndrome and some of the other cases. This is also another incomplete one where part of the hard palate is also involved, but the alveolar ridge is always intact. So if you find the alveolar bone is complete and only there is a cleft in the soft or part of the hard palate, these are called the incomplete hard and soft palate. This is a real full cleft, which also involves the lip and going up to the alveolar bone. And the last one, it is a bilateral one. So you find there is a gap here, there's a gap here, the central portion alone. This is the premaxilla. Okay, so this is the type that you will see in very rare cases. So this is a pictorial description. These are the similar same cases with the outward as well as inward look. So you can, this case is this. What you see, the last one, complete bilateral cleft. This is how it will look. If you open the mouth, there's a gap here, there's a gap here, and this projection here. Whereas this one, this is the unilateral cleft. What is described in stage 3 is the unilateral cleft. And this one will be again this type of cases, which has been, this is the soft palate partial cleft. Okay, so all these cases are there with the actual patients also. So if they ask you what is the definition of a cleft lip, it is a birth defect that results in a unilateral or bilateral opening in the upper lip. So unilateral cleft lip is like this, bilateral will be like this. And if it is a palate defect, it's again a birth defect characterized by opening in the roof of the mouth caused by a lack of tissue development. Okay, so this is the normal oral cavity. patient's head is tilted and mouth is open, you find a intact alveolar bone, you find a normal hard palate, normal soft palate, and a single uvula. And this is the tongue. It is almost like a Malamati examination. You find a normal appearance. Whereas in the left side, unilateral cleft lip and palate. This is a case of left-sided cleft lip and palate. So you have a defect here, you have a defect in the alveolar bone, you have a defect in the both hard and soft palate, and uvula is in two pieces. And this is a bilateral cleft where you have a defect right from this nostril up to the uvula. So you can easily identify these types if you remember these pictures. Now coming to the developmental anatomy or embryology, there are medial and lateral nasal processes. These processes are sometimes also referred to as frontonasal processes. So this blue and red, what you see, this red is the lateral nasal process, blue is the medial nasal process, and this is the maxilla. This is green is the maxillary process. So they are all clubbed together and they are separate from each other. Okay, so there is a big gap here, and above the maxilla you find the eyes are developing in the baby. This happens at the 4th week of gestation, in the first trimester, and gradually before the 8th week, that is within 1 month of time, what will happen? This gap will get slowly narrowed, and these two medial nasal processes will unite together, and lateral nasal process will form this ala of the nose. Okay, so this will form the medial part of the nose, and this will be the maxillary bone. So maxillary bone, medial process and lateral process on one side, combining or joining with the same similar structures on the opposite side results in the normal formation of the lip. If they don't join like this and they fail to fuse like this, then you get what is called a defect or cleft in the lip. So this is the picture to show the normal where is this? Right. Okay. So this is the normal area. This is what is this depression all of us who have. If you don't grow a mush, you can always palpate this. This is your depression in the upper lip, which is called the philtrum. Okay. From the top of the philtrum, your nose will start, and that thick portion that is separating the two nostril openings is called the columella. And this philtrum has got an edge here, which is called the philtral ridge. And at the end of the philtrum, where it joins the upper lip, there is something like a bow, which is called the Cupid's bow, which is there should be the normal way the lip should be. And there is a line which is drawn here, which is the connection between the skin and the mucous membrane. So the upper lip or the lower lip is rolled out and made. The mucous membrane is covering part of the musculature that is there in the formation of the lip, and it joins with the skin. So this is also called the white roll, white skin roll, or the vermilion. So they are mentioned here as white skin roll and vermilion. So when there is a defect here and they try to unite, they should try to reconstruct this complete shape. Then only it will look like a normal lip. But in majority of the cases, the gap will be so much that most of the structures will be either shifted to this side or that side. So this normal anatomy you have to know to appreciate whether the surgeon is doing a good work or not. So you can see nicely this portion is called the philtrum. This is called the Cupid's bow. This is called the vermilion border. This is the mucous membrane. Normally these tubercles are also there. And this nose, this is what is called the columella. This is the ala, and this is the groove, alar facial groove. And this is called this lower portion is called the nostril sill. Now again, this is how a secondary palate formation. We saw first picture, we saw about the lip formation. In the palate formation, the same maxillary bone has got what is called the palatal shelves. So that palatal shelf will start growing inside the mouth into, again, they are made up of two pieces. They will slowly come down and the tongue will be in between that. So that is why in Peary-Robin syndrome, the tongue will not allow to fuse these bones of the maxilla. That is why the cleft the palate happens in Peary-Robin syndrome, because of the underdevelopment of the mandible. The tongue projects into the gap. Whereas in the normal patient, it will come, the tongue will be lower down, and you will be, these two bones will be able to come together and they will fuse ultimately. So here is a normal 10th week. So 7th week it starts, 8th week it comes to join. By 10 weeks, you find both this yellow area is called the primary palate. So the junction of the primary palate and the secondary palate or the hard palate, there is a small opening which very difficult to see, but this opening is there, which is called the incisive foramen. So any area in front of the incisive foramen is the primary palate, behind is the secondary palate. And the incisive foramen, you will have a hard part of the bone beyond the primary palate also. There, 4 teeth will grow as the child grows. The 4 incisors will grow, and you can see in this picture, it is like a triangle. This is the primary palate, and you find 2 incisors on the right and 2 incisors on the left will be growing there. So imagine if you have a defect here, these teeth cannot grow. So patient will not have adequate teeth. So they may have to do another corrective surgery as the child grows older, what is called the alveolar bone graft. They have to bridge the gap in the alveolus and then implant a tooth later on. So all that dental work has to be done. So if a child is born with a cleft lip and palate, till they reach adulthood, they may need some correction surgery or something. Now, what is the reason for that? There have been various theories, but main reason is failure of fusion between the median nasal process and maxillary process. If you mention this one particular sentence, that's all. Exam, you can pass. You will not be asked further questions, because many of the examiners themselves may not know or remember the theories that are there. And what are the unilateral? Again, some pictures to show unilateral complete and incomplete and bilateral. Repeatedly, I'm showing just for you to remember in the exam. Again, these are all the actual patients, that repetition of the old picture. Now, what is the etiology? This you should know. Sometimes majority of the time it is genetic factors. It can be caused by nutritional defect during the development because mother is not eating well. Physiological and emotional and traumatic stresses also can cause this development, or defective vascular supply to the area involved. That may be the reason. And the mechanical disturbance when the size of the tongue may prevent, as I told you in Peary-Robin, or environmental factors like infections, rubella, exposure to radiation, drugs like thalidomide or anti-epileptic drugs. Supposing mother is an anti-epileptic and she takes it, she is on anti-epileptic medication or hormonal pills or quinine taken for malaria. All these things can affect if they take it in the first trimester, because the development is between 4 to 10 weeks. And maternal consumption of alcohol or smoking also has been said to be one of the causes for the cleft lip and palate. And the classification, of course, morphologically, people like Davis and Ritchie, Viavu, and embryologically, so many people have classified. You don't have to bother about that. But this Viavu's classification, most examiners are fond of asking. He has classified the lip into class 1, class 2, class 3, and class 4. Class 1 is only a simple notching, and class 2 is a incomplete one. It's not involving up to the nose. Class 3 is complete, goes up to the nostril 4, and class 4 is bilateral cleft. So this is what is called Viavu's classification of lip defect. Then he himself has classified the palate. The class 1 palate is a purely soft palate, and then incomplete, again soft palate and part of the hard palate. Third variety is involving soft palate, hard palate, and alveolar bone, which is otherwise called the unilateral complete cleft, and it can be bilateral. Okay, so these are the 4 types in lip and 4 types in palate described by Viavu. Of course, we will not go into all these other types for want of time. So this just at least know the names. And what will be the clinical feature if the patient has a facial deformity or a cleft? It can be the nose tip deviated to the normal side, ala on the cleft side of the will be flared, nostril horizontally oriented, lip deformity will be there, hypoplastic and a collapsed maxilla on one side of the cleft, on the side of the cleft and the cleft palate. So usually you will find that left-sided face will be little down when you make the baby lie on a table and look from the head end. The normal side will look more prominent because of the maxilla will be well developed there. Whereas on the defect side, it will always be on the little lower side. And for bilateral clefts, additional features like protruded premaxilla, small prolabium, absent columella, and shallow gingivolabial sulcus will be there. And because the inability to suckle on the mother, nasal intonation will happen later on if the cleft palate is not corrected, and nasal regurgitation will be there. Then the why you want to correct all these things, because first is the appearance, especially if the baby is born with a cleft lip. It is a stigma. People keep on asking why it is like this, and so for aesthetic purpose, you have to first correct it. Second, it is not able to create adequate negative pressure to suckle the milk. Excessive air intake can happen, aerophagy. Child may get repeated choking. They may have nasal regurgitation, especially in cases with complete palatal cleft. And speech defect and hearing problem can happen later on, and recurrent respiratory infections can happen. Now, what are the syndromes associated with that? We can just check your knowledge on pediatric. I will show the pictures. If you can name it, you can just unmute and say. Can you identify this baby? What syndrome it is? Look at the facial features. There is a cleft lip, complete cleft lip. You can see the defect going up to the nostril, and alveolar bone is also not there. No teeth has developed there. You can see a lot of teeth on the lower jaw. So the child is a little grown up child. But what about the eyes?
Down syndrome, sir.
Very good. It's a hypertaylorism and Down syndrome child. Good. Can you identify this condition? At least what is the defect after I have shown you all these pictures? Can you identify
Complete cleft lip with involving the alveolus. Bilateral.
Bilateral. First say bilateral complete cleft lip. Okay. So this is a complete bilateral cleft lip. But what are the two depressions you see on the lower lip? I think none of you would be able to tell. This is called the Vanderwood syndrome, and these depressions are called Vanderwood pits. In this Vanderwood syndrome, invariably the father of the child also would have had the same defect. So it runs in the men folk. So if a father is having, child will having, male child will have. So that is the peculiarity about this Vanderwood syndrome. And these depressions are the things which tell you that this is a condition. So Vanderwood spits they are called. What is this child? Okay. Where is the ear? Is the ear normal? It is
below the.
Normally the ear should be in line with the eye. If you draw a line from the lateral canthus of the eye, the ear should be situated there. So is it in that level or well below? It is well below.
Well below.
It is called low placed or low position ear, and you have the difficult small mouth opening. So this is what is called the Treacher-Collins syndrome. And this baby, this is a very, very common thing. If you, unfortunately, if such a patient is available, they will definitely keep it in the examination.
Perry Robinson.
This is a Perry Robinson syndrome. You can see the straight mandible. So normally you are supposed to have a jaw like this, and then the neck should come. That is called the sternomental angle. So normal sternomental angle should be more than 100 degrees. But here what happens, there is no, because the small mandible, there is no proper growth. So that will look like a straight line. And these children usually have only a incomplete cleft of the soft palate alone. So it won't even enter into the hard palate. So if this child comes, it's a very, very challenging, tough opportunity. I mean, case for management. So you have to go for only inhalation induction, preserving the spontaneous respiration, and try to intubate with the child breathing spontaneously in a deeper plane of anesthesia, so that you don't land up with a situation of CICV. You can't intubate, can't ventilate. Okay. So I have had experience of anesthetizing only 3 such cases in my long career with plastic surgeons. And this is the Peary Robin. And what is this? You find the baby's neck is almost stuck to the body. There is no neck at all.
Klippel syndrome.
This,
Klippel
this is called the Klippel syndrome. And this is another common child you would have come across. Can you see any defect in the fingers of this child? Can you identify what is that condition?
Syndactyly.
Syndactyly, very good. This is syndactyly. How is the frontal bone? Is it bigger or smaller?
Bigger, sir.
Bigger. Bossing of the frontal bone and the mid-face retrusion and the small jaw. This is called the Apert syndrome. So most of them have palatal defect. They also have only incomplete soft palate defect, which may require surgery, and they are also quite challenging for airway. So all these syndromes, especially Down syndrome, which may have a easy chance of subluxation of the cervical spine. Okay, that is the danger when you position for intubation, and these all the cases pose their own difficulty. So we have to be very, very careful. Now coming to the management of cleft lip and palate, it is a multidisciplinary approach. You cannot just depend on one surgeon and one anesthetist to correct this thing. So you require, sometimes ENT surgeons may be involved and they also do these repairs themselves. But for the CSOM or ear infection, you have to consult them. Then you may need a plastic or a oral surgeon who handle these patients regularly. You may need the help of orthodontist or prosthodontist for correction of the teeth repair and other things. You may require a pediatric dentist, an ophthalmologist, a psychiatrist to console the mother and the parents or the relatives, speech therapist. Once the child with the cleft lip palate has been operated, some of them still have the nasal tone for a long time. So you have to give speech therapy, and the nursing support is very, 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 very important. Now that you have a matron here, she will know the nursing support is very, very important, and social worker. So we used to have all these people in Stanley. Every Tuesday we used to have a cleft lip and palate clinic, and all these people will assemble there and they evaluate the child completely and give a total advice and correction. So it requires a important teamwork. And what are all the surgeons, treatment that may require? The first month of their birth, you may require initial assessment and pre-surgical orthoptics. Especially you can get the feeding difficulty corrected during this first month assessment itself. Then 3 months we try to do the lip repair. At 9 to 18 months we do the palate repair. And the reason why sometimes they may ask you why you choose to do it by 9 months, because that is the time all children start to utter the syllables or start phonation. Until then they will not be able, they will be crying only, but no phonation will occur. So before they start speaking, you should correct it. Then only you can have a normal quality of speech. And at 2 years, you must assess the speech after the repair. And 3 years, sometimes they may require a lip revision surgery or a palatal hole may be there. The surgeon would have repaired the palate, but one portion of the palate would not have healed and form what is called the palatal fistula, through which still the regurgitation can happen. So they may require recorrection of that palatal fistula. And at the age of 8 months, you start doing the alveolar bone grafting. What I told you, this bone will not grow. Even if you attach just the mucosa covering the bone, underneath the bone will not grow. So there will be a sort of dimple-like thing. So there they will take a small part of the tibial bone and insert it here and then cover it with the mucous membrane so that new bone growth will form and that bone will get solidified, on which the orthodontist can work and produce the teeth and implant the teeth. So 10 years alveolar bone graft, 12 to 14 years, you start repairing the teeth. 16 years, especially nasal female patients, you may require a nasal reconstruction or nose correction. And 17 to 20 years, you may have to do some orthognathic surgery. And this one formula, sometimes I found listening to some of the videos on the ISA Kerala and other people discussing the cleft lip palate cases. One examiner was very fond of asking about the expected weight of the baby. So he was asking about this Veach's formula, where 3 to 12 months, that is less than 1 year baby, you always take the month of the age of the baby, add 9 and then divide by 2. Some people take even less than 3 years in best guess formula, age in months plus 9 divided by 2. So for example, when we are discussing about a 3 months old baby, 3 plus 9 will be 12. 12 divided by 2 will be 6. So if the baby had a birth weight of 3 kg, what Mubin presented, 3 months old baby should weigh at least 6 kg according to this formula and this formula. Most of the formulas are like that only. But 1 to 6 years, you can multiply the age in year by 2 and add 8 to that. More than 7 to 12 years, you multiply the age in year minus 5 by 2 in one formula, or this best guess formula is very easy. You always multiply the age by 4, you will get up to 5 to 14 years. So I thought I'll include this also for the benefit of you. So you can note down later on and remember them. So these are all the prostheses. This is what is called the acrylic prosthesis which you can fit in. You can see actually it has been fitted into the mouth and the gap has been closed. It's a transparent one. So every time before the mother feeds the baby, she can fix it into the gap and then the baby will be able to easily swallow. So this is fabricated individually for each patient, and this is called the obturator, the name of this gadget which you use for feeding. Sometimes it can be permanently fixed with wires and then kept in position. You can see in this case. And there are special feeding bottles available for overcoming the feeding difficulties, which is called the Med Johnson bottle and Haberman feeder bottle, where instead of the normal nipple portion alone, you have some more space, like a spacer in your inhalation equipment. And there is a nipple later on. So the child will not get too much of quality, milk flowing out of the bottle, and it can drink in small quantities without getting aspirated. Now this is another pre-surgical orthodontics which is done for creating a good functioning palate and normalize the tongue position. And what you see in this picture is called a Logan's bow. So in very wide clefts, when they have operated, even before surgery and after surgery, there will be a lot of tension on the suture line because the tissues have been wide apart and they have brought it by dissection and brought them close to each other by like this. So there is a chance that they can dehisce. So in order to keep them in position, just putting a plaster may not be of use. So they use this petal clip-like thing which will keep the cheek together. So that is what is called the Logan's bow, and they use it prior to the surgery also to prevent the lip separating apart. That's why I told you lip grows faster. The more you wait, the gap becomes more and more. So you try to correct it by this, and this is how the infraorbital block is given to tolerate that. This is one side they are blocking. You will see more pictures of that later. So this is how a good repair should look like. This is a incomplete cleft of the lip on the left side before surgery, and the surgeon has beautifully sutured it. You can find the philtrum is recreated. Here there is no philtrum at all, what I showed you. this columella is turned towards this side, to the normal side. So he has brought it to the midline. He has created the philtrum and he has created a normal nostril floor. And you can see this ala which is flared up is now made shorter. So all the defects have been nicely corrected. So this is a very good repair. And you find this cupid bows is also nicely formed. And the vermilion is finely, nicely aligned. So this incomplete lip has been repaired, and this is a complete lip which has been defected, and that also has been very reasonably nicely operated. And this is the palatal defect. Can you find any defect in this? In this first picture A, do you find any defect? What is the one?
बोला सर
Huh?
bifid बोला
Yeah, there is only uvular is in two pieces, but you cannot see any other gap. But this is a type of cleft. What is this cleft called? There is no bony deformity. There is no bony separation. All over you are finding the mucous membrane, but only the uvula is in two pieces. But if you see this underneath, does it look like a normal color of the palate? Does it look slightly different from this mucous membrane?
Congested, sir.
Not congested. Bluish
Bluish.
tinge is, it is a little more bluish tinge, isn't it? This is what is called the submucous cleft of the palate. It is under the mucous membrane. So in these cases, if you put your finger and touch, there will be a hole. So, but it is covered by the mucous membrane, but you identify that condition only by the bifid uvula. They will always have two pieces of uvula. So if you dissect, you have to again do a repair, close the inner defect and then reposition this palatal mucous membrane. Okay, so this is called the submucous cleft. So this is after the repair of what that has been done. Submucous cleft with a bifid uvula. This is again a bilateral cleft with incomplete, which has been again nicely reconstructed. The beauty of correction is only in creating a good philtrum and making the ala and the nostril sill normal. If that is achieved, that means it's a beautiful repair. Otherwise, the surgeon is not good enough. Again, you can see what type of cleft this is. I have shown you so many pictures. Now you tell me what type of cleft it is. Complete or incomplete?
Complete left-sided lip with involving the alveolus, sir.
There is no alveolus. Nice teeth has grown here. How do you say it is alveolus? It is incomplete. It has stopped at the hard palate level. Okay. So it is an incomplete one. If it goes into the alveolus and primary palate, then only you can call it as a complete one. Okay. So this is an incomplete cleft of the palate, which is now repaired. You can see this nicely, beautifully repaired, and there is no gap at all. Okay, now this is what this is called the submucous cleft, which is there with the bifid uvula, again identified by the bluish tinge. That is the only indicator that it is a submucous cleft. And the diagnosis of this condition can be made in the antenatal period in the mother itself. Nowadays, we do the ultrasound scanning and 3D ultrasonography right at the early months. So, because the lip formation is complete by 10 weeks, the 20th week anomaly scan itself sometimes can give you a clue about the presence of this. So, nowadays, we insist on diagnosis of all the congenital anomalies in the antenatal period itself, so that we can take a decision whether to do it in the fetal uterine life itself or immediately after surgery. So the advantages of early diagnosis include there is time for parent education on the management. It allows psychological preparation. So mother and relatives will not be taken by surprise that such a defective baby has born. It gives opportunity to investigate for other chromosomal abnormalities. So you can do a lot of genetic engineering work and give parents a choice of continuing the pregnancy or trying to. This may sometimes be the cause for some of the marital problems. The husband and the other people may degrade the lady and give her a lot of mental tension. So all the decision can be taken, and it also helps in getting prepared for the neonatal feeding and care and opportunity for a fetal surgery. In fact, so many papers were presented long time back. In Paris, they tried to correct a lip defect in the fetal life itself, intrauterine like exit procedure. They have tried correcting it in the intrauterine life itself. Now, this is for the benefit of all the students who have not watched lip or palate repair surgery. This is the palate repair surgery position. And for lip, this will not be so much of extension, but for palate, they definitely require a palate extension like this. All of you would have seen a tonsillectomy. It is more or less like that. But nowadays, what they do is they don't keep these two rolls here because it makes the thorax more upward and the limbs are downwards. So they have found that babies positioned like this, they have more pooling of blood on the lower limbs, so venous return gets reduced and cardiovascular intraoperative instability happens. So what they prefer to do is place the baby on a pillow. The full body is placed in a horizontal position in the pillow, and the head alone is allowed to hang from the edge of the pillow. So this position is altered now by placing the baby on a pillow with the head hanging down like this. This is the draping with the ray tube fixed to the lower jaw in the central position, and now the surgeon is applying the mouth gag. So this is for a palate surgery, the position and the steps, how they are preparing for that. And so next thing is, after he applies the gag, this tube usually goes under the tongue blade. So there will be a groove for that, and the tongue blade will accommodate that ray tube. And you can see this is the upper clamps on the upper jaw. So if you have a wide cleft and you have a alveolar discontinuity, it will be very difficult to apply because one portion of the alveolus will be normal, other portion will be very short and in a downward fashion. So application of this clamps for the upper jaw will be very, very difficult, and novice surgeons will find it very difficult. They may take half an hour to properly apply the mouth gag itself. By the time you will get frustrated. So you can see the bifid uvula and all the mouth nicely exposed. So mouth gag in position. Then invariably they will mark all the lines where they want to make the incision and raise the flap, and then infiltrate the mucous membrane with a adrenal and saline or with the local anesthetic. In Stanley, we used to infiltrate tumescent local anesthesia so that you can have both analgesia and hemostasis. But sometimes the examiners may ask you, supposing the surgeon wants to infiltrate adrenaline saline, he doesn't want to infiltrate local. How will you advise? He asks you what is the dilution, how I prepare the solution. How will you advise him? What is the method of preparing the adrenaline saline for infiltration? How much of saline you have to take, how much of adrenaline you have to add to that? Very simple. You have to prepare a 1 in 200,000 solution. So you add 1 ml of adrenaline to 200 ml of saline. That will give you what is called 1 in 200,000. Because the regular preparation 1 in 1000. So to that you add 200 ml of saline, it becomes 200,000. Okay, so each ml will have only 5 micrograms because 1 ml is 1 milligram, which is 1000 milligrams, 1000 micrograms. And if you add 200 ml of saline, you will roughly get 5 micrograms per ml. And you can add, you can use 5 microgram per kg body weight. So if your child is 4 kg in weight, you have to use only 4 ml of this diluted solution. Okay, 1 ml of adrenaline to 200 ml of saline, out of which surgeon can use maximum 4 ml for infiltrating into the whole area. And being a small baby, that will be more than sufficient to infiltrate. And once you infiltrate properly, this pinkish, this reddish color of the mucous membrane will become completely white and pale. That is the beauty of this vasoconstrictor effect, and you will not have any systemic effect of tachycardia or hypertension. So epinephrine infiltration for the markings of the flap, and this is how you give the orbital infraorbital block, both extraoral approach and intraoral approach. Extraoral approach, 1 centimeter from the ala of the nose and 1 centimeter from the midpoint of the lower margin of the orbital ridge or orbital bone. So you just go and hit the bone, inject only 0.5 ml of your 0.25% sensorcaine, not more than that. That concentration is more than enough. So 0.5 ml in this position and 0.5 ml in this position. So you have to give bilateral block because they are going to dissect both this side as well as this side. So always you must give a bilateral infraorbital block for all lip surgeries. This is the intraoral approach. If it is an older patient, for intraoral approach, you can find the canine tooth and then put the needle underneath and reach this point from the intraoral aspect. You can see the needle tracing going down up to this. Whereas in a toothless child, in a 3 months old baby, you won't have a tooth. So you always aim to the same external point from underneath the lip. So going underneath the lip through this, you go to this bone, hit the bone and then deposit just lateral to that about half to 1 centimeter. You will be successfully blocking these nerves. So these are the two approaches of infraorbital block. Now, what are the challenges in the cleft palate? Mostly pediatric patients, which are infants below 1 year, may have anticipated difficult airway, especially if it is a syndromic cleft, and problems of sharing the airway with the surgeon, because palate, especially when they operate on the palate, you will be sharing the airway with the surgeon. And if the child is more than 6 months, you always have the separation anxiety when you take the child away from the parent. And NPO guidelines to be followed strictly to avoid complication. Anesthetic technique to be planned in advance based on the airway challenges. So if you anticipate difficulty, always go for inhalation induction and not intravenous induction, and never paralyze the child in a anticipated difficult airway. Keep the spontaneous going on. And pharmacokinetics and pharmacodynamics of the drugs to be learnt well, because children have, especially small infants, have lesser function of the liver as well as the kidney. So you have to be very, very careful in the usage of drugs. Watch for 3 hypos: hypotension, hypothermia, and hypoglycemia. And the infants desaturate faster because of the low FRC and develop bradycardia, unlike adults who develop tachycardia. So bradycardic arrest because of desaturation and hypoxemia is very, very, very common, especially in children less than 1 year old. So you have to be very careful in maintaining the oxygenation. And positioning of them for surgery may result in loss of airway, especially in palate surgery. When you put them in neck extended position, the tube can migrate unless you have taken proper care to fix them in correct position. And postoperative respiratory complications like obstruction and laryngospasm and aspiration to be anticipated in these patients. And there are 3 reasons for postoperative restlessness in children after surgery. One is mainly hunger, second is pain, third is airway compromise. And lastly, older children may also have separation anxiety if they don't see their mother. So instead of regularly dumping them with any analgesic or sedative, you must identify. If you are given a block, if you are given suppository, if you are given fentanyl, 100% pain will not be the cause. Whereas if the wide cleft palate operated and the nasopharynx made smaller, the child will definitely have difficulty in breathing through the nose. So the restlessness will be mainly because of the airway compromise. And if that is not the reason, you have adequately sucked out all the clot and blood and made sure that the air passage, the nasopharynx is quite free and child is able to comfortably breathe, then hunger will be the third reason. So just a spoon of water or something after 2 hours will be all that is required. Or if the child is a little older than 6 months, you always put the baby on the mother's lap. That will be the best sedation for the baby. So don't try to unnecessarily give midazolam or fentanyl and land up in complications. Now, what are all the equipments needed for this particular surgery? Is usually use this Jackson-Rees modification of ISTPs, which I have told you. Can anyone identify what is this for? There is a cap closing something here.
Capnography, sir.
Huh?
Capnography.
Capnography attachment. Very good. It is the outlet for your ETCO2 sample line connection. Okay. So what is this portion called? This L-shaped portion projection. Any name for this? This is called the elbow connector. Okay. So this is a modification of the T-piece. It is not going straight like a T. Okay. It is a elbow connector with a fresh tube. This green tube is the oxygen connection or the fresh gas flow inlet. Okay. So this has been connected there. This is the expiratory limb to which this is a bag that has been adapted but has been modified by adding a valve here, which was not the original description by Jackson-Rees. And these are the, what are these things? What are these things? Have you not seen this?
Anatomical face mask.
Anatomical face mask. Any other answer?
Rendell Baker.
ஐயோ தப்பு. நல்ல ஒரு ஆன்சரை சொல்லிட்டு அடுத்தாப்புல உடனே சொதப்பிட்டியே.
Suspension.
Transparent scented face mask. Okay, these are all transparent. Older masks were all made of black rubber, so they were all not transparent. Now this is the smallest size mask, 1, 2, 3, 4, 5. Okay, whereas the older we used to have 00 and 10 size mask also for neonatal, premature children. But normally we have 5 sizes of mask. What are these plastic things on the neck of it? What is this for? Some 4 projections are there attached to a ring. What is it for?
The suspension.
For strap connection, sir, for non-invasive. Non-invasive ventilation.
Oh, no.
They used to attach a strap from the.
Not non-invasive. To give rest to your hand instead of holding it, they used to have what is called the saddle to fix it to that. So especially in UK, they commonly use it. They have a 4 straps which will be, there will be a pad with the 4 straps which will be kept behind the head, and you can hook it onto that so that it will stay in place. So you don't have to strain your hand holding it until the completion of the surgery. So majority, olden days, British anesthetists, they complete most of the surgeries holding the mask itself. So this is called the holder for that, which is still continued, which we don't use nowadays. But it is used as a color coding for identification of the size. Okay. And what is this? Very commonly seen.
Macintosh laryngoscope.
Macintosh laryngoscope with various sizes of blades. So normally for a 3 months old baby, we have to choose this particular blade. Okay. If you don't have, you can go for this, but this may likely to traumatize the epiglottis. So as far as possible, go for the smallest size blade so that you don't cause any injury because of that. What is this shown here? All trained, very experienced pediatric anesthetists commonly do this. They don't require a second person for intubation. What are they doing here?
Glottic pressure with the. To improve the vocal cord visualities.
Is it called? Is it called a glottic pressure? Single-handed burp application. Okay, so the surgeon, the anesthetist is using it. He has a long finger, luckily, so he is able to push the trachea, give a little compression. So
Backward,
backward,
upward.
upward, rightward pressure is applied by his own fingers. So you don't require anybody else to help him. What is this?
South facing ray tubes.
Oral ray, south face,
Oral ray.
oral ray, nasal ray. That will be a much better description. And
Okay.
they may ask you about the advantages and disadvantages of using this tube for cleft lip and cleft palate surgery. Can you enumerate one or two? What is the advantage and what is the disadvantage of this tube?
Suctioning will be
Advantage.
very difficult with this tube, sir.
Very good. That is the disadvantage. First, why don't you talk positively and then go negative? What is the positive point about this? It is a preformed tube, nicely anatomically shaped, and it will not be compressed or it will not be displaced. I mean, kinked. So it will be happily sitting under the tongue blade. Okay, that is the first advantage. And there is no disconnection chances because you have a universal adapter nicely fitted into that, and through this you have to go for you can attach, remove this, you can attach this to this portion and then ventilate the child. Whereas the disadvantages, as you said, is one, it is, you cannot apply suction because it is curved like this. And the other advantage is the length is fixed. So in children, if you don't choose the correct size, you can make either an endobronchial intubation, or if you have put in a smaller size for an older child, it can migrate out when the surgeon adjusts the tongue blade. So migration of the tube is another problem with this. Otherwise, this is a wonderful equipment. So ray, oral or South Pole ET tube is the name of that. What is this? I don't know how many of you would have seen this at all. This was the tube that we used to use as a postgraduates for lip and palate surgery.
Robert sir.
This is called the Oxford ET tube, which is made of red rubber. The characteristic of this, sometimes some of the hospitals may still be having this. So if you are unlucky and land up in such centers for your examination, they may ask you this. Definitely they will keep to at least tease you to find out whether you have any inclination to read the history. So this is a red rubber tube with an angulation almost like a 90 degrees. This portion which goes into the trachea with a beveled edge will be a softer portion. And this portion, as it becomes outside the mouth, it will be very thick. So because you cannot directly connect it to the circuit, you need another connector. And that connector is this, which is called the McGill metal connector. So in those days when we were postgraduates, we'll have to insert this here. Then there will be another tube connected to this end, which will be connected to the circuit. And the pity of it, in those days, we had this Jackson-Reese circuit made of metal, which was very heavy, unlike the present day plastic. So this connection will very often come out, especially if there is some secretion or anything, this connection will come out, or it may disconnected here from the what is called the catheter mount. And third, the catheter mount to the tube, because it is a metal heavy connection, that will also very much disconnected. So before the surgeon starts, at least 4 or 5 times we will have to go under the drape, fix everything, and have our heart in our mouth, because the child will desaturate, become little blue. Then we'll have to hurriedly ask the surgeon to take off the gag. It was hell in those days. Can you identify this bag? Okay, this is called the Kuhn reservoir bag. One of the modifications, instead of having a valve here, somebody thought after all what Jackson-Reese wanted was to avoid any valve. So somebody made a hole in the center so that you can close that and ventilate the baby. Okay, so this is called the Kuhn reservoir bag. And these are the various types of IV cannulas. What is the difference you find in this IV cannula which you routinely use?
George தானே
Huh?
18
I can't hear you properly. If anybody finds out the difference between the regular Venflon you use and this, I will give you ice cream.
That flange is liftable, sir.
There is no injection port in this. Normally, this blue usually will have an injection port, isn't it? But usually yellow and this purple, they don't have because you have to have an adapter, whereas blue usually will have an injection port for injecting the drug. So that is not present in this. Okay. So these are the IV cannulas. 22 gauge is blue coded, 24 is yellow color, and purple 26. And you require sometimes, if this sort of cannula is used, you require, what are these?
Extension.
This is
Three
only an
cannulas.
extension. This is a 10 centimeter three-way extension. This is a straight three-way tap. Okay, there is no extension tube in this. So you have to put this into the cannula and then insert your IV line here. Okay, so this is other equipment if you need, if you don't have an injection port. Otherwise, you can't give the drugs. And so this is a three-way extension. What is this?
Pediatric burette.
This is a pediatric IV set with the burette, so that you can measure the volume and fill it so that you don't overload the baby. Okay, so burette IV set is required whenever the child is less than 10 kg. It is safest to have this particular set. And what has been done here? It is the stabilization of the wrist. So wrist stabilizer, otherwise, the children with difficult veins, if you don't take care properly, they may shake and the whole thing may come down and you will be struggling to get another vein. Okay. These are all, sometimes you may get a peri-Robin child which may have a problem like this with a very short mandible. And sometimes during birth itself, they may have severe problem of respiratory obstruction. So they may, first thing they may ask you if a peri-Robin child has a newborn, neonate infant. I mean, neonate has a difficulty in breathing and desaturates. What are the methods by which you can help the baby as a intensivist when there is no pediatrician or neonatologist to attend on the baby? How can you help the baby? Put the baby in prone position first and foremost, because you want to, this is the tongue falling back which is causing the problem. So you have to put the baby in prone position to take the weight of the tongue away, or you can insert a oral or nasopharyngeal airway. So here you can see a baby with a nasopharyngeal airway. In this case has been so severe that they have made a tracheostomy itself. Okay, so that severe may be the case, and this is how the oral defect will look in them. And what is the pathophysiology for this peri-Robin syndrome is, it is mechanical theory, neurological mutation theory, and mandible compression theory. But the main problem is underdevelopment of the mandible. So micronanthia. Because of this, the tongue becomes larger for the normal oral cavity. So it is called glossoptosis. And this will cause airway obstruction in the baby. These three are the characteristics of that peri-Robin sequence. So previously they were calling it as peri-Robin syndrome, but now they call it as sequence because the primary defect is with the mandible. The mandible is not grown properly. So there is a small mandible. Because of that, the normal tongue looks like a bigger tongue. It goes and falls back on the posterior pharyngeal wall, completely obstructs and causes airway obstruction. And in addition, they may, because of this growth, as I showed you in the earlier picture, it will not allow the palatal shelves to fuse. So they develop a cleft palate, which is mainly in the soft palate area, because the forward bone gets fused, but the softer palate will not be able to fuse together. And that is why they always get an incomplete soft palate defect. So the problems in these cases will be, it is an anticipated difficult airway. Because you cannot push the tongue into, unless you have a large mandible, you cannot push the tongue into the space. So visualization of the glottis will be difficult. And during extubation also, you have to, unless you make a child fully alert and recover with all the reflexes and with no pain, you have to anticipate extubation problems like laryngeal obstruction or the laryngospasm and other abnormalities. If they are born a little premature, they can go for apnea of the newborn. Sometimes if they are having a severe degree of obstruction and they are operated say at the age of 2 months or 3 months, by the time they could have developed carpal tunnel because of the chronic hypoxemia, and feeding abnormalities also may be there. Now to relieve this, sometimes they do these procedures. What is called the tongue lip adhesion or glossopexy is performed in the neonatal period. So they make a incision on the lower aspect of the tongue. The tongue sutures, they have pulled out the tongue, they have made an incision, the lower lip is everted and a similar incision is made, and these two raw areas are attached together by sutures, and after that you can see the tongue is permanently attached to the lower lip almost, so the tongue will be protruding out all the time, and they have put a artery forceps to show the gap between the lower lip and the other portion of the tongue. So this is what you achieve. Initially, before repair, the tongue has occluded the pharyngeal opening to the larynx. Now, after they pull it out, there's a good gap there. And another treatment that is now opted for these children is what is called the mandibular distraction osteogenesis, where they put some pins on the mandible, make a small osteotomy and keep on distracting this bone away, just like your Elizarov technique to lengthen the bone. So you can see this is the pre-op picture. You can see the straight line here, and after the distraction, after 6 months, you can see nicely the straight line is gone, the mandible has grown up to this. So this is another treatment that is being given nowadays for palate, distraction of the mandible, so that you can operate on the palate comfortably without any risk. So these patients may come for cleft palate surgery. They exhibit very severe opioid sensitivity. So if these cases are being done, rely mostly on paracetamol and local blocks. Don't go for opioids, so that you can avoid respiratory depression or difficulty post-operatively. Sometimes they may require radiological or magnetic resonance imaging for using this, what is called this last procedure of mandibular distraction. And for the palate, you can give what is called the greater palatine and lesser palatine nerve blocks, which are normally done in our institution when we used to operate. The surgeon himself will do. When they raise the flap, they will be seeing that foramen through which the nerves and the vessels emerge to supply the palatal mucous membrane. So there we ask them to infiltrate 0.5 ml or 1 ml of 0.25% bupivacaine intraoperatively, and that gives an excellent block. Or otherwise infiltrating with the tumescent or local anesthesia with xylocaine, adrenaline, that also is sufficient for pain relief if you do a palate repair alone. But most of the anticipated problem, you should be wide clefts when you repair and close them. They initially have some difficulty in breathing with the smaller nasopharyngeal air passage. So they may struggle in the initial phases. And many of the surgeons don't prefer using a nasopharyngeal airway because that may go through the suture line of the palatal flaps and disrupt it. So what I used to do is I just insert it only a small distance, so that the children will have a good passage for breathing. The anterior part of the nasopharynx you can safely insert and or put them on the lateral position. That is also a good technique to relieve this problem. So these are the things that you have to remember this. Kamachi, do we have time for continuing?
We have already covered 2 hours and 30 minutes, sir.
So I will stop here.
Yes, sir. Can we have the Burns case for next week, sir?
Yeah, that's what I think.
Okay, sir. Okay. Students, any doubts from students, sir?
Yeah, they have to tell me. Any doubts you want to ask? Vasanti madam is there?
No, sir. She had some urgent call. She left at 6
Okay,
o'clock.
she left. Okay. Okay. So I'll be happy if you get some idea about how these surgeries are done. Do you feel that, Pratik, what do you feel? Pratik Shukla, are you there?
Sir, yes, sir. Yes, I am here, sir.
You said you have not done a case or seen a case at all.
Yes, sir. I
Now,
haven't seen.
now do you get some idea about how to manage this case?
Yes, sir. Somewhat. Yes, but just how to manage, sir.
Okay.
Sir.
So if you people don't have any doubts, can I close this?
Yes, sir.
Okay.
Sir, thank you very much, sir. Thank you
you.
very much for a very useful and extensive session on a very important learning session for our PG students, sir. And it has given a lot of insight for our postgraduate students, not only for this Cleft Palate, how to be a very safe anesthetist. Plan your anesthesia, know your case, know the challenges, prepare your infrastructure, theater, equipments, know what are the drugs you are using. Before touching the patient for any anesthetic procedure, our anesthesiology fraternity is always a well-prepared team. So you should be able to handle any unforeseen situation. So most of the situations have been extensively studied, and our experienced teachers have gone through all those difficulties. With all their experience, they have made life much simpler for us by sharing their knowledge and experience. So I request all our students to make full use of their shared experience and knowledge and skills and make surgery and anesthesia safer for our patients. Thank you, sir. Thank you so much. Thank you, students.
Thank you.